Okay, everybody, this is going to be the third time that I have recorded this lecture. Yes, it has irritated the crap out of me. I failed to recognize when I said I would record a lecture for you guys that I had any idea how to actually do this. So this is my third attempt, having gone through all of this 2 other times and not having it save appropriately. So, third time's a charm. I've gone fishing this morning. I've caught a couple fish, so I'm feeling a little better about life. But we're going to roll on chapter 5, which is tissues. And they describe them as living communities in our chapter. And it is actually a pretty good chapter. So I am going to recommend that you read your textbooks for this. So in general, tissues are basically the cells that we've been talking about clustered together, working as a functional group. And we have 4 basic types of tissues in the body. Those are epithelial tissues, which work to primarily cover and line things. Connective tissues, which help to provide support for pretty much all of our body. Muscle tissues, which allow for movement, and then nervous tissues. And nervous tissues really allow the work of the body to be done by allowing it to communicate with each other. So we're going to start with epithelial tissues, and this lecture is going to be really heavy on epithelial tissue and connective tissue. Muscle and nervous system really kind of has their own whole chapters that we're going to deal with at later dates, but we will touch on them a little bit. So in general, epithelial tissue is just sheets of tissue that cover and line other tissues. It helps to filter out biochemical substances, helps to absorb nutrients in different portions of the body, allows for provision of sensory input, and it helps to manufacture secretions and excretions. As general characteristics of epithelium goes, that is generally organized into sheets. Every one of our epithelial cells is polar, and what that means is that it's got a top surface, or the apical surface, and a bottom surface, or the basal surface. And those basal surfaces are often anchored essentially to connective tissue, as we will find out later in this lecture. The side-to-side or lateral surfaces connect each other to neighboring cells. And important to know about epithelial tissue is that most epithelial tissue is avascular, meaning it does not have blood or lymphatic supply. And most epithelial tissue is also innervated, meaning that it has nerves running into it. The attachments of epithelial tissue, there's 3 big types of what we call junctional complexes. The first is what are called tight junctions, and you find those in tissues where it's really important that there are not any leaks. So the bladder and the GI are good examples of tight junctions within epithelial tissues. And then you can also have something called desmosomes, and desmosomes are Velcro-like kind of plaques between the cells that interlock not only with each other side to side, but the desmosomes also have little tonofilaments that go through the cell tissue on either side, allowing it to be very, very strong. So these are important and found in tissues that undergo a lot of stretching and a lot of tension. Now, this schematic is not designed to represent any one particular type of tissue. It is designed to just illustrate the 3 basic types of adhesions between cells, with the top one up here being tight junctions, the second one down here being the desmosomes with these kind of interlocking filaments between, and then these tonofilaments that kind of branch out through the adjacent cells. And then this third type here is what are called the gap junctions. And the gap junctions are really important in our cardiac muscle and in our smooth muscle. And those gap junctions, those little, they look a lot like vaults do in the schematic representation of nuclei, but those are called connexons, and they go from one cytoplasm over to the cytoplasm of the next cell and allow for exchange of passage of ions and nutrients. And they can quickly transport electrical signals between cells too, which makes them extremely helpful in cardiac tissues. All of our epithelial tissues have the basement membrane, which is the basal lamina, and it is the kind of foundation or cement that allows epithelial tissue to sit on top of connective tissue and not get sheared off. It does also act as a partial barrier to the underlying tissues. Again, this is just a schematic of the gap junctions between cells here, just as a visual representation. Now, epithelial cells can also have surface specialization. That means on the apical or the top surfaces of epithelial cells, they may have some different features that allow them to perform optimally in their target tissues. Blood vessels in general have very smooth surfaces, whereas small intestine contains numbers and numbers and numbers of what are called microvilli. And those microvilli, their primary role is to increase surface area of a cell. And microvilli are found primarily in the small intestine. You can see where that would be very, very helpful for that cell to have as much surface area as possible in order to help absorb nutrients and water and electrolytes. Now, cilia are kind of a larger form of microvilli, and we talk about cilia with respect to the respiratory tract primarily, but cilia really have that microtubular backbone to them, and cilia allow things to be moved past the cell. So that is their primary purpose, as in coughing up mucus in that respiratory tract. And then our skin epithelium is what's called keratinized, which means it gives it a harder surface to make it more resistant to damage to the exterior. Again, schematic representation of what some of these things look like. Microvilli, here they're shorter, smaller, way more numerous than cilia are. Both of these terms can be called a brush border. And then again, we have our basement membrane here at the basal or the bottom surfaces of our epithelial tissue that allows it to be cemented to the underlying connective tissue. Now, epithelial tissue can be classified in a boatload of ways. It is either simple or it is stratified. And simple layers just have one cell layer thick. Stratified have more than one. Epithelial tissue is also classified based on the shape. So squamous cells are flat, cuboidal cells are square, and columnar cells are tall. And they are also classified as to whether or not they have these surface specializations on them. So they can be called smooth epithelium, microvillous epithelium, ciliated epithelium, or keratinized epithelium. So our squamous epithelium, again, these are the flat ones. Cuboidal are square, columnar are tall. These three illustrations all demonstrate a simple layer of each. And this bottom illustration represents a stratified or multi-layered portion of your epithelium. Now, there is this other type that kind of falls into simple, yet we call them stratified, but we call them pseudo-stratified. And the big defining feature of pseudo-stratified epithelium is that in spite of it being truly a monolayer or a single layer of cells, the nuclei are all at different heights, essentially. But if you look closely, you can see that they are all adhered. Every single one of these cells is adhered to that basement membrane. So they call them falsely stratified or pseudo-stratified. And those are super important in respiratory tissues. So our simple epithelium is generally delicate, very thin. We see this most commonly in the lung, in the kidneys, and in the blood vessels. So surfaces that are involved in the passage of gas or liquids through them are often lined with simple epithelium. And the lung is a great example of a simple squamous epithelium. I think we looked at some lung tissue under the microscope week before last. And again, this is gaseous exchange or liquid exchanges a lot of times are where we're going to find this single layer of flat epithelial cells. Now our stratified squamous epithelium, which are the multi-layered, this diagram here just gives us two different schematics. One of what is considered non-keratinized stratified squamous epithelium, and that's the type of epithelium that you find in oral cavities and in the esophagus. And then what's called keratinized, or that harder epithelial tissue that is highlighted by the skin surface. So in the skin, you've got this, what they call the cornified layer, and this is the layer that's constantly kind of sloughing off. Now your oral tissues are also sloughing off these stratified squames, but this cornified, you have this extra flat layer of cells that just provides external barrier, a stronger, firmer external barrier for protection, essentially, of the underlying tissues. Now, cuboidal epithelium can be simple or can be stratified. We find a lot of simple cuboidal epithelium in areas where there is active secretion and absorption going on, so in glands and ducts. Whereas with our stratified cuboidal epithelium, generally stratified cuboidal is only 2 layers rather than the multiple layers that we'll see in the stratified squamous epithelium. Stratified cuboidal is a protective type of tissue, and it's found largely among excretory ducts. So simple cuboidal epithelium, best place to find this is in kidney tubules. This is a photomicrograph of a cross section of a kidney tubule. Right here is a tubule. This is the lumen, or the inside of the tubule, and you can see all these cells around it fall into this simple cuboidal epithelium type. Now, our stratified cuboidal, again, 2 layers: sweat glands, mammary glands, and salivary glands. So in our salivary glands here, this looks a lot similar, not a lot like our kidney tubule, but we have this multi-layered with this larger duct and the duct lumen here where we'll find our stratified cuboidal epithelium. Columnar epithelium comes in kind of 3 basic categories, but the stratified is pretty uncommon. But our simple columnar epithelium, we'll find those in some cells that are associated with absorption and secretion, in particular what are called the goblet cells, which produce mucus. And then our pseudostratified columnar epithelium, again, the nuclei are at the different levels. Not all the cells reach the luminal surface, but they are all attached to the basement membrane. Most pseudostratified columnar epithelium we see in a body is ciliated, and so the respiratory tract is really where we're going to see a lot of this pseudostratified columnar epithelium. This stratified columnar, sometimes we'll find it in some excretory ducts, particularly in the urethra of some species of animals. Simple columnar, again, from the stomach all the way to the rectum, is composed of simple columnar epithelium. This schematic representation shows you the goblet cells that are interspersed within the simple columnar epithelium. And these goblet cells are super important in the production of mucus. Moving on to the stratified columnar, which we don't find very much of. So mammary ducts, and in some species in the male urethra, is where we'll have the stratified columnar. Again, the thing that makes them columnar is the shape, whereas with stratified squamous epithelium, we will have those flat layers of cells. The urethra is really the one that we'll think of in terms of that stratified columnar epithelium. Now, the pseudostratified, as I mentioned earlier, respiratory tract, respiratory tract, respiratory tract. So these are ciliated. All the cells are, in fact, attached to the basement membrane, although this does not show us a really good representation of the fact that they all are attached to the basement membrane, but this little diagram does. Most of these are, in fact, ciliated. Again, remember those cilia in the respiratory tract, they're constantly trying to push things toward the mouth to get them out of the respiratory tract. So particulate matter, mucus, microbes. Now, there's this other type of epithelium, which is very important, called transitional epithelium. And transitional epithelium is found almost exclusively in the lower urinary tract. So the ureters, the urethra, and the bladder. Transitional epithelium is kind of a group project. So you've got one layer of cuboidal or columnar cells, and then on the surface of those cells are squamous shaped cells. And the design of transitional epithelium is so that it provides for a leak-proof membrane in areas that expand and contract. So you can imagine your bladder, your urethra, those are expanding and contracting much more so than our gastrointestinal tract is. And those are lined with that transitional epithelium to help with that. Again, lower urinary tract is where we find this transitional epithelium. So the surface cells are more squamous in shape. The underlying cells are more cuboidal in shape. Now, moving on to glands, which are collections, essentially, of our epithelial tissue. Glands are groups of cells that manufacture and discharge secretions. And remember from our chapters 3 and 4, secretions are an active process, and they are proteins that are made in the rough ER, packaged by the Golgi, and then discharged from the cell. Classification of glands is by either type of gland, whether it's an exocrine gland or an endocrine gland. And the thing really to know about endocrine glands is that they do not contain any ducts, nor do they contain any tubules. And secretions from endocrine glands are going to be distributed throughout the body. And endocrine, for you guys, if it isn't already, is going to become synonymous with hormones. So most of our hormone producing glands are what we call endocrine glands. So other ways that we can classify glands is by the number of cells that compose them, the shape of the ducts that they may have, how complex the structure of those glands are, the type of secretions that they produce, and the way in which they store and discharge those secretions. Now, exocrine glands that are unicellular, the only example is that ever important goblet cell. Goblet cells are modified columnar epithelium, and they secrete mucin or mucus, and they're found in columnar cells of the respiratory tract and the digestive tract, as well as in the conjunctiva in the eye. So when you get those kind of goopy eyes, those are your goblet cells doing their work. Now, multicellular glands have both a secretory unit and a duct. That secretory unit is generally surrounded by connective tissue. It's very rich in blood vessels and nerve fibers, and it may be surrounded by what are called myoepithelial cells. So breaking that word down, epithelial cells are what we're talking about as far as tissue type. But myo, we know from our studies, it refers to muscle. So myoepithelial cells have the ability to contract, which can be very helpful when we are secreting things from these glands. So the rate of secretion production is often controlled by hormones, which again are usually endocrine glands, as well as nervous system impulses. So schematic here of the goblet cells that we saw in the GI tract. Again, they're also present in the respiratory tract. They produce mucus. So our ducts of exocrine glands, they can be either simple, meaning that the duct is not branched, or they can be compound, which means that the duct is branched. And then they can also be classified based on their shape. So you can have tubular glands that are just one long tube. You can have alveolar, or also called acinar glands, which have a rounded sac. And then you can have a combination of both, which is tubulo-alveolar or tubulo-acinar. And so it has qualities of both. And the way that these products are secreted is an important factor in classification of these glands. And so merocrine secretion is where the secretions are packaged and they're released via exotosis as they're manufactured. So there's no damage to the cell. The cell doesn't lose anything as they are secreting these. And we see merocrine glands most commonly in the pancreas, the sweat glands, and the salivary glands. We can also have apocrine glands, and mammary tissue is a good example of an apocrine gland. The glands in these situations, the cells actually store their secretions, and that top portion of the cell is kind of released into the duct system as it is letting go of whatever glandular secretion it is producing. That top portion of the cell then goes on to repair itself, and so it's losing part of its cell as it is discharging its secretion. And then we have holocrine glands, and holo means all, and so you can think of all of the gland or the cell, the entire cell, holo, is destroyed when that product, the glandular secretion, is released with holocrine glands. And the sebaceous or oil glands of the skin are the most common example of this. Here's a schematic representation of the three types of glands based on how they get rid of their secretion. So the merocrine glands just release it via exocytosis. The apocrine glands release a portion or the apical portion of their cell, and then they repair that portion of the cell after they release it. And then these holocrine glands, that whole cell is sloughed off along with that secretion within the gland. So the types of secretion is also a descriptor for different types of exocrine glands. So some exocrine glands can produce serous or watery discharge. Serous discharges often have a high concentration of enzymes, or they can have mucus type secretions, which are thicker and more viscous. And mucus is largely composed of glycoproteins that we studied in cell production the last couple chapters. Or you can have mixed, some that produce both serous and mucus components. So on to connective tissue. So that's our quick summary, quick 20-minute summary of epithelial tissue. Connective tissue is also another large portion of this chapter. Connective tissue is incredibly important in our bodies. It's what holds us all together. It allows it to have structural and metabolic connections between tissues. It protects our organs by providing a sheath around them. It helps to insulate our body. Connective tissue serves as a reserve for energy and general framework, and also is important in the transport of substances from one place in the body to the other. And our connective tissues also have an important role in the healing process, as well as helping to control invading microorganisms, and we'll talk about that at the end of the lecture here. General characteristics of connective tissue. Important to know that this is the most abundant tissue in the body by weight, and connective tissue, unlike our epithelial tissue, is vascularized, meaning it has blood and lymphatic vessels going through it. Most connective tissue, if not all, has 3 different components to it. Those are called the ground substance, the extracellular fibers, and then the cells of connective tissue. And common examples that should all be familiar to you guys of connective tissue is tendons, fat, cartilage, bone, and blood. Believe it or not, blood is classified as a connective tissue, and that kind of makes it my favorite. But so what is ground substance here? Ground substance is the medium by which the cells exchange nutrients and waste with blood. It is amorphous, meaning it doesn't have a shape, and it is homogeneous, meaning that is a similar consistency through the entire substance of the ground substance. And it's composed mostly of glycoproteins. That ground substance protects delicate cells within it, as well as envelopes the connective tissue, and helps to provide an obstacle for microbes that are trying to invade. Extracellular fibers in the connective tissue are the second basic kind of contributing factor to connective tissue, come in different shapes and forms. There are collagenous fibers in some connective tissue, which are strong, thick strands of protein collagen. They're organized into bundles. They have varying densities and varying arrangements depending on where the collagenous fibers are, and they often surround our organs. So tendons and ligaments predominantly are made up of collagenous fibers. Now you can also have what are called reticular fibers, and reticular fibers are much more fragile. They're thin, they're delicate, they're branching little networks of collagen, and in general, they provide support or help provide the structure for highly cellular organs like the lymph nodes and the spleen and the liver. Once you start getting your hands on the spleen and the liver, you'll notice like how easy it is to crush those things, and that is because they are mostly reticular fibers rather than in some of our other more dense types of connective tissue. So we'll also find these reticular fibers in nerves and blood vessels, as well as muscle fibers and capillaries. And then the third type of extracellular fiber is elastic fibers. And so these are, like the word elastic connotates, they're stretchy. And so they often branch to form complex networks, and they are found in tissues that are more prone to stretching, like the vocal cords, the lungs, the skin, and walls of blood vessels. So cell types within connective tissue, you have 2. Fixed cells, which are always there in connective tissue, and those are predominantly fibroblasts in a lot of these tissue types. Now, as we go on to differentiate types of tissues, you'll see the terms chondroblast, osteoblast. Those are tissue specific. So chondroblasts are in cartilage, osteoblasts are in bone. Adipocyte refers to fat cells, mature fat cells. And these cells are largely involved in the production and maintenance of the matrix of the cell. And then you can have transient cells, which transient cells, just like the word transient connotates, is they can come in and they go out. And they do that through a process called diapedesis. And this term does have close relation to the term pseudopodia from our last chapter, where things like use false feet to crawl in, crawl out. Transient cells are those that are largely involved in the repair and protection of tissue. So macrophages, which use their pseudopodia to crawl in and crawl out, as well as leukocytes, which is the general term for white blood cells, and mast cells. And mast cells are tissue of the allergic and immune response that contain large amounts of histamine. So when we classify connective tissue, we can also classify connective tissue just like we can classify epithelial tissue. It is generally either considered loose connective tissue or dense connective tissue. And loose has 3 types, dense has 3 types. Now with our loose connective tissues, areolar tissue is probably the largest proponent or contributing factor to loose connective tissues. You can truly find areolar tissue everywhere in the body. And areolar tissue is just kind of a mishmash tangle of random fibers that are suspended within this thick ground substance. The predominant cell is the fibroblast, and its job is to support and surround tissues, help provide nutrients, and it's present in all mucous membranes. Now, in disease states or in the pathologic state of areolar tissue, this is where we reflect back to the term edema or fluid accumulation in connective tissues. And we know that edema is a consequence of low albumin and the changes that result in oncotic and hydrostatic pressure. Now, pitting edema, this term refers to a type of edema that you typically are going to see most in the skin. And pitting edema is like if you push your thumb or your finger into a tissue and you remove it, you'll still be able to see a pit, essentially, where your finger was. That is what pitting edema is, and it is a clinical term that we use in tissues. So areolar tissue contains elastic and collagenous fibers, and so this little square here is the lower aspect. And the dog's barking. I have 3 or 4 in here, and somebody thinks somebody is coming to attack us. But this little square of tissue, if you kind of blow it up down here, it's a photomicrograph of the different types of tissue. And the ground substance is kind of the space between here, guys. The elastic fibers are these little smaller, darker staining ones. And then our collagenous fibers are going to be our thicker kind of sheets of collagen. Now, adipose is also a type of loose connective tissue. It is also a type of areolar tissue in which the major cell type is the adipocytes, and that is just a fancy word for mature fat cells. We have fat all throughout our body. Fat is highly vascular, and there's 2 main types of it. There's white fat and brown fat. And this brown fat, interestingly, we will see brown fat most commonly in newborns, newborn mammals of all types, and we'll also see a large proportion of brown fat in hibernating animals. And brown fat, its job is actually to help thermoregulate and produce warmth for these guys. And so you can see where it would be important in both newborns and in hibernating animals. Brown fat gets its name from its color, and the brown color in brown fat is largely the result of high numbers of mitochondria in that tissue, and that makes it look brown. So fat in general, though, is an energy storehouse, it's a thermal insulator, and it's a mechanical shock absorber. And so when we look at fat tissues underneath the microscope, what you will see is that the largest portion of the cell is all these fat droplets within the cell. It pushes the nucleus and all the other organelles over to the side of the cells. And so we get these colored-looking cells that are our fat cells. Now, reticular tissue is another type of loose connective tissue, and these are kind of interesting. Very thin fibers, very loosely arranged, and there's fibroblasts as well that are suspended in ground substance. In reticular tissue, there are no collagenous fibers and there's no elastic fibers. And these types of loose connective tissue allow to provide a framework for our internal organs, and particularly the spleen, the lymph nodes. You also see a lot of reticular tissue in the liver as well. So this is just a small little kind of photomicrograph of what spleen tissue looks like underneath the microscope. So all these little spots here are representing red blood cells, which there are a large number of them within the spleen. The spleen is a filtration organ as well as a reservoir organ. And then these reticular fibers that are the reticular connecting tissue that make up the structure are all kind of interlaced within, and You can see where the lack of density in this type of tissue would make it more prone to injury. So moving on to our dense connective tissue, we've got two big types, dense regular and dense irregular. Dense regular connective tissue is a lot of our tendons and ligaments and what are called our fascial sheets. And our fascial sheets overlie our muscles. You guys will start to see those as we get into dissecting our cats. Thing to know about regular dense connective tissue is that it's very slow to heal. Now, our irregular dense connective tissue has some thicker bundles of collagen in it. Instead of having nice parallel sheets, they'll be kind of irregular looking, and the most kind of prominent location for irregular dense connective tissue is going to be in the dermal layers of our skin, as well as the capsules of our organs and our joints. So dense regular connective tissue, highlighted by ligaments and tendons, looks a lot more like this with our parallel collagen fibers, and we see our little fibroblast nuclei in there. And our dense irregular connective tissue is mostly skin and organ capsules. So again, you see they're not at those nice parallel sheets that we saw in that dense regular tissue. This dense irregular tissue is more irregular in appearance when we look at it underneath the microscope. So elastic and specialized connective tissue is also kind of subsets of their own. This elastic tissues are mostly elastic fibers, and we'll see those in ligaments as well. Your ligaments do in fact stretch more than your tendons do, as do the walls of the arteries, the stomach, the bladder, the heart, the bronchi. So anywhere that requires stretching is going to have a higher number of elastic fibers in them than those collagen fibers. And specialized types of connective tissue include cartilage, bone, and blood. And there's a couple different types of cartilage that we're going to talk about as well. Cartilage in general is more rigid than dense connective tissue, yet it is more flexible than bone. Cartilage in general does not have any innervation to it, and it does not carry a blood supply either. The major cell types in cartilage are called chondrocytes, and they live in little spaces called lacunae. Their matrix is ground substance, tissue fluid, collagen, and elastic fibers, and we find cartilage in the joints, in the nose, in the vocal cords, and as a framework for bones. Now, different types of cartilage, there are three. There is hyaline cartilage, there's elastic cartilage, and then there's something called fibrocartilage. Now, our hyaline cartilage is the most common type, and it's also the most rigid type. And so these cartilage cells and tissues are closely packed fibers, and they're enclosed within something called a perichondrium. Now, where we'll find this is in the rings, the C-shaped rings of the trachea, the auricular cartilage, or the cartilage of the ear canal itself, in the growth plates of long bones, and in the sternum to the rib connections. Whereas elastic cartilage is going to have a higher concentration of those elastic fibers within it. They're often dense and they branch off, and it's a lot more flexible. And we'll see elastic cartilage in the epiglottis, which you guys will start getting eyes on as we start intubating animals next semester, as well as the external ears. So the external ears are called the pinna. That's an important vocabulary term for you guys to know, but that is where we'll find more elastic cartilage. So the hyaline cartilage, or the rigid cartilage, we'll see this in the costal cartilages are composed of hyaline cartilage. So you can see microscopically, you've got these chondrocytes. They live in these little spaces called the lacuna, and you've got your perichondrial layer that goes over it. And in between all this is the matrix, or some of the ground substance. Now, our elastic cartilage looks a little more different in that we have these little elastic fibers running through it. And again, elastic cartilage, the pinna of the ear, the epiglottis are good examples of that. Now, fibrocartilage is another type of cartilage that is kind of a merger, essentially, group project of hyaline cartilage and dense connective tissue. Thick bundles of hyaline cartilage that do not have this perichondrium, or around this layer around the cartilage. Fibrocartilage, we'll see it most commonly in areas that we think of as kind of joint-like, but different joints, not our hinge joints or gliding joints like shoulders, ankles, and knees, but in joints that are areas that are really designed to take compression. So between the bones of the spine, between the bones of the pelvis, pelvis, and in the knee joint, the menisci. If any of you have ever torn your meniscus in your knee, those are all examples of fibrocartilage in the body. And so you can see this type of cartilage looks real different than your hyaline and elastic cartilages do, and that it is really, really dense with these collagenous fibers and fewer in number of these cartilage cells. Now, bone is its own specialized type of connective tissue, and bone is really cool. Pardon me, I'll skip back there. It's our hardest and most rigid, as you guys are all aware of. Bone has a very specialized matrix, so it has collagen fibers, but bone has a high proportion of inorganic calcium salts within it. Bone is also well vascularized, whereas regular cartilage is not as well vascularized, and instead of lacunae, it has its own central haversian canal, and then it has these smaller canals called canaliculi within it. And we're going to talk a lot more about bone. It gets kind of its own chapter coming up soon. Now, blood is my favorite type of connective tissue because it's one that you may not think of initially as a connective tissue. So when we start to break down blood, we talked about blood as a suspension because when you take it out of the body, it settles. The blood cells settle. We also talked about blood as a colloid when it's in circulation in the body because you have large particles that may not refract, that will refract light. But when we think about blood as a connective tissue, we break it down into the plasma, the proteins, and the cells. So the plasma, or the liquid portion of the blood, you can think of as the ground substance. The proteins that are contained within the plasma are what we consider to be the fibrous component. And again, the most important blood protein, guys, is albumin. Albumin is largely responsible for oncotic pressure. Hope you got that right on your exam. Now, the cells of blood, red blood cells obviously are the most predominant, and then leukocytes is a general term for white blood cells, and then we also have thrombocytes or platelets in the bloodstream. And so that is kind of how we classify blood as a connective tissue. Now, membranes are kind of the process of protective layers of these tissues linking themselves together. And membranes consist of an epithelial sheet with an underlying connective tissue proper kind of membrane, or between the two, they are a membrane. So we've got a group project going on. So we have epithelial and connective tissue that forms these membranes. We've got 4 common types of membranes in the body. In the mouth or anywhere that is external, it connects with external of the body, you tend to find these mucous membranes. So the respiratory tract, the oral and digestive tract are considered mucous membranes. And then we have things that don't contact the outside of the body, which we call serous membranes. And the pleura and the peritoneum, both are vocabulary words from chapter 1. Pleura is your thoracic membrane lining, and the peritoneum is your abdominal membrane lining, the abdominal cavity. And then you also have your synovial membrane, which surrounds your joints. Now, there's another type of membrane that surrounds the heart, specifically called the pericardium. It's a really cool thing. Small animal folks, if you do any emergency work, you will see diseases of the pericardium, and they're not a lot of fun, and there's no good causes of them, but we're going to talk a lot more about the pericardium in upcoming chapters. But mucous membranes, those are ones that can have connections to the outside environment. Their epithelial layer is stratified squamous or simple columnar epithelium, and the lamina propria is the connective tissue portion of that membrane. Now, the submucosa is what connects mucosa to underlying layers, and submucosa becomes very important when we start talking about surgeries, particularly of the GI tract, because that submucosa is a very, very strong holding layer. Mucous membranes typically produce large quantities of mucus, therefore they contain goblet cells, which is our unicellular glands, but they can also contain multicellular glands. And some mucosa also have the ability to absorb nutrients. For example, in the intestine, the epithelial layer is important in nutrient transfer. So breaking down our types of membranes, guys, we have our cutaneous membrane, which is our skin, our serous membranes, which is the pleura and the peritoneum in the chest and in the abdomen, respectively. We have our mucous membranes, which line our oral cavity and the GI cavity, as well as portions of the respiratory cavity. And then we have our synovial membranes, which is our joint membranes. Now, synovial membranes, one thing that makes them a little bit different is that they don't have an epithelial layer to them. They just have this connective tissue layer. And it's loose connective tissue, some fat cells, dense connective tissue, and synovial fluid. So there's no epithelial layer in joint tissues. The third type of our four here that we're not going to talk about in as much detail is muscle tissue. Muscle tissue is very fibrous and is designed for contracting. It is consistence of actin and myosin and has myofilaments that slide over one another. Three basic types of muscle tissue are skeletal, smooth, and cardiac, and they look very different underneath the microscope. Skeletal muscle is voluntary muscle, and it is striated muscle, and striations refers to actin and myosin amounts, and those are able to be visually seen underneath the microscope. Important thing to know about skeletal muscle cells is that they have hundreds of nuclei and mitochondria within. Now, the impairment of the ability to contract muscles is paralysis or paresis. Paretic or paralyzed are clinical terms that we refer to a patient with when they cannot move all of their muscles, some of their muscles. So we can describe a facial nerve paralysis, or we can describe a hemiparalysis or hemiparesis, which means the back end of the body. So again, this is our skeletal muscle here, and these are striations in the skeletal muscle. Cardiac muscle and smooth muscle, also important, and we're going to talk about them in their own chapters as well. But our cardiac muscle is only found in the heart. Cardiac muscle has special cells called pacemaker cells. Cardiac muscle cells, unlike skeletal muscle cells, only have one nucleus. And they have these really special little junctions between them called intercalated discs. So cardiac muscle falls into a category of involuntary muscle, but is also considered striated. Again, schematic representation of our three types of muscle cells, cardiac being in the middle here. So it does have some striations like our skeletal muscle does, not as many, not nearly as many nuclei either. And then smooth muscle. Smooth muscle are small spindle-shaped cells. They are not striated and they are not voluntary, meaning we cannot control them. We find them in walls of hollow organs like the blood vessel, the bladder, and the stomach, and our intestines. And our smooth muscles are largely responsible for what's called peristalsis, which is how things move through a tubular structure. You'll hear this term most commonly with the GI tract. Diagrammatic representation of the innervation of smooth muscle. So smooth muscle in the stomach here, smooth muscle in the what's called the ciliary body, or the little muscle that controls the iris in the eye. Cardiac tissue we mentioned, and then nervous tissue is the last type of tissues in this chapter. Nervous tissue is designed to receive and transmit electrical signals through the body. Nervous tissue is in the brain, spinal cord, and peripheral nerves. Important to know is that the neurons are the longest cells in the body, and for right now, all we're going to know is that there's three big parts of the neuron: the perikaryon, which is the cell body, the dendrites, which are the terminal portions or the end portions of the nerve, and the axons, which are the long processes by which electrical impulses are transmitted in the body. Now, phases of healing. This is a complex but very important kind of area. I would highly recommend that you read your chapter about phases of healing, because it is very important to know, because that's a big part of our job, is to help promote healing in the body. Pardon me. Inflammation is step one. Inflammation is a non-specific response to injury or disease. It starts with constriction of blood vessels, and then later on, those blood vessels then dilate to help bring nutrients and macrophages to the damaged tissues. Inflammation also involves edema. And edema is really where pain comes from in the inflammatory process. You get irritation of the nerve endings and swollen tissues, and it causes pain. So this is that kind of dull, throbbing pain that you may feel when you've got a sprained ankle that's swollen. Inflammation does involve clot formation on a microscopic level or a macroscopic level sometimes, phagocytosis, or the eating of microbes or dead tissues or dead tissue substance within the body, as well as release of histamine and heparin. And these are very potent mediators of inflammation. They're also potent mediators of the allergic response in the body. As a general terminology note, guys, anytime that we talk about infection, more technical definition of infection is inflammation in the body anywhere caused by microbes. And so if we have, whether it's bacterial, viral, or fungal, if we have inflammation in tissues occurring as a result of microbes, that is what we term infection. Step 2 of the phases of healing is wound repair, and that starts pretty quick overall, and it involves the formation of granulation tissue. And granulation tissue is very heavy in collagen fibers and very heavy in capillaries, or teeny tiny little blood cells. It's got a lot of phagocytosis, or eating of dead tissues and microbes, going on within wounds. And you horse people may know granulation tissue as proud flesh. We'll see exuberant proud flesh sometimes in horses, particularly on their limbs, where that epithelialization, or the step 3 process in tissue healing, where you've got your granulation bed, and now the body comes and starts to put epithelial tissue over the top of all that granulation or connective tissue. With proud flesh, a lot of times there's so much granulation tissue that epithelialization cannot take place over the top of it. And so as a consequence, with our horses or with any portion of the healing process where we have exuberant granulation tissue, sometimes we actually have to go in and remove some of that granulation tissue surgically. But this step of regeneration is also called fibrosis. It is where epithelialization occurs. It is where scabs fall off, if we're talking about the skin. And it's where we have scarring forming. And it's also the point in the show where you can have adhesions. And we'll see this most importantly in body cavities, particularly those doodles that are on foreign body surgery number 3. In the process of healing from their previous 2 surgeries, or even 1 surgery sometimes, or even just a simple spay, some animals really want to form adhesions, and so you'll get the serosal membranes of your intestine adhering either to each other or to the wall of the body. So instead of opening up a patient and having a nice, normal, what you expect as far as distribution of organs in the body, you can have all those guts kind of clumped into one big ball, or you can have a portion of the bowel adhere to the body wall, so that when you go in and make an incision, you're at greater risk of lacerating an intestine as you make your surgical approach. So wound healing in general can also be classified as first intention or a second intention. For our purposes, first intention healing is when wounds are close together, when the edges of a wound are close together. So if we suture things together, we consider that first intention healing, where the formation of granulation tissue is very limited and you don't get nearly the scarring involved, versus second intention healing. So if I have a larger wound, or if I have a wound that is heavily infected, sometimes we have to let that wound essentially heal from the inside out, is how I describe it for clients. And we call that second intention healing, meaning there is greater amount of granulation tissue, there's a greater amount of scarring, a greater amount of contracture when everything is said and done with second intention healing. There's about 9 pages of key terms in here, guys. I have highlighted them all in red, the ones that I think are important for the time being. So I would definitely encourage you to work on knowing your definitions of these. Some of them, again, we'll go into more detail about in following chapters. But in general, that is the end of the tissue lecture for the 4th time. And I'm going to cross my fingers, please, and hope it records.